right, so we're going to be looking at diseases part 1A, which is the diseases that affect the skin. And we've selected 3 diseases which we think are most important, or at least most interesting and relevant. So the first one is a bacterial disease, which is caused by Staphylococcus aureus. And these, there are several different presentations of the disease that is caused by staph in the skin. And when we call it a staph infection, that's what we're talking about. Then the viral disease that we selected was chickenpox shingles, and the protozoal disease we selected was leishmaniasis. And so these are just a sample in the disease unit. Really what you're going to be looking for is this something that is caused by what kind of organism is it? How do we diagnose it? How can we then treat it? How can we prevent it? So in all of these diseases, that's what you're going to be focusing on. This is sort of a culmination of everything we've been talking about. How does the immune system fight it off? You know, what are the treatments? What are the, how do we diagnose this? And so all of the things that we've been dealing with, and this is in this last unit. So we're just selecting some that we feel like are relevant and something that is interesting for this day and age. And so without further ado, we'll be looking at the staph infections. So the type of infection we're going to start with is the staph infection. And so when we deal with a staph infection, we're saying something is caused by Staphylococcus aureus typically. And so this infection, it takes many different presentations. The least severe of this would be a folliculitis, which is an infection of the hair follicle, like an infected hair. So furuncles, which is also called a boil, and carbuncles, which is a series of boils. And so when we talk about folliculitis, the least severe presentation, this would be something like if you were shaving and you gave the staph bacteria that are pretty much existing as a normal microbiota on your body and in your body, but mostly, you know, like in the normal, it's the skin and the mucous membranes in the nose and the mouth, but particularly in the nose. If somehow that bacteria gets onto your skin and then is taking up residence there, maybe microbiota, part of your microbiota, and it gets in through a cut in the skin. And that's why a lot of times it's like a shaving instance where you have shaved and you have cut your skin, you've made a way for the bacteria to get in. This is on almost all of these situations, you're going to be looking at something that has a pus-filled lesion. And as you saw in the previous slide, which I'll go back to now, you can see this is a furuncle. You can see with the, you can see that this has the pus-filled lesion here. And that would just be a single pus-filled lesion. That would be a furuncle. So folliculitis, it may have a red, tender, maybe an abscess, but it's really, until it has this pus-filled lesion, I don't know that I would call it a folliculitis or a furuncle. I wouldn't call it a furuncle until you had the pus-filled lesion there. And then the carbuncle, you can see it's a series of these. You can see that there are 3 little pus-filled lesions kind of fused to make one big giant one, and it's hard to tell, you know, how big that actually is from the scale of this picture. But that would be essentially the difference between the carbuncle and the furuncle. And so when we look at this, the furuncles are going to be something that is a result of a folliculitis that may have gone further, maybe deeper, or it may have had more severe, more virulence factors involved. But it is a large, tender abscess. That is pretty much the identification of a furuncle. And so it's an abscess is one that is hot. It is red. There's just a ton of inflammation going on, and there's usually pus in the lesion. So, and pus is usually made up of dead bacteria cells and also white blood cells and there are just a lot of phagocytes in that area where there's the abscess going on. And it's sort of the result, it's the debris of the battle that is going on between the bacteria and your white blood cells, the phagocytes that are first getting into that area. So usually this resolves unless it gets further infected. And when it gets further infected, you have something like carbuncles here. And so this is on a larger area, and it is deeper. It's usually in thicker skin, like the back of your torso and the back of the neck. So thicker skin, and it can be systemic if it gets into the blood. So if you have septicemia, and that's when it's most deadly. That is the most severe issue. And this is pretty much either a furuncle or a carbuncle. This is what we typically see when you have a MRSA infection, MRSA, which is methicillin-resistant Staph aureus. And that has now become multi-drug resistant Staph aureus. And so that is a typical kind of thing that we would look for with a staph infection. And these things, when we are talking about prevention, it's all about hygiene and preventing that bacteria from getting into a cut. If you do get a cut, you really should clean it and make sure that you cover it up to prevent further, infection of microbes and their ability to get into the skin. So what causes the problems? The disease itself, the symptoms, the signs and symptoms we see with this are exfoliative toxin A and B, which we will talk a lot about in a little bit, but exfoliation is what it basically does. It removes the upper layers of the skin or destroys the upper layers of the skin and separates it from the epidermis from the dermis. And also coagulase, which causes coagulation in the blood. And so these two things will be the thing that causes it to make disease in your body. And then there's this prevention. We talked about hygiene, so you really have to just clean it. And then treatment is with antibiotics that the culture is sensitive to. Note that that is really important here because many of the Staphylococcus aureus bacteria that we find in the community transfer situations where you get it communicable, from somebody in the community, or you get it just not in a hospital. Let's put it that way. So community-acquired staph infection is very likely to be resistant to typical things like penicillin and maybe even methicillin. Now, not a huge percentage. Penicillin, like 100% of the cases that we have seen in the community. MRSA infections are about 6% of the population. And so it's not a huge percentage of the cases, but it is still, that's a pretty high percentage of the MRSA or of the staph infections. So 6% of all Staph aureus infections are MRSA. So the story that I have for this is a guy, and I just have to show the picture again to kind of illustrate this a little bit better. But a guy comes into the ER in Wichita. I had a student who actually worked in the ER, and he had been my lab assistant at one point, and then he came back, and he was telling me this story. And this, basically, the idea behind this was, he had a person who had let this infection go pretty far, and he was a mechanic, and you could see the grease under his fingernails. Like, he obviously didn't really do a lot to clean it off. And after he was done for the day, and he was scratching his neck, and he's like, I don't know how it got so bad. And, scratching it where the actual infection was located on the back of his neck. And that infection was a carbuncle about the size of a grapefruit. So if you can imagine that on the back of your neck. So just go grab a grapefruit and just think about that. So it was pushing into the skin. It was obviously very painful. And sometimes these things can take less than a week to develop. So you would be surprised how quickly it can go from being just a little pimple looking thing to being this huge abscess on the back of your neck. This resulted mainly from him just reinfecting it, though. And so they had to cut it out, debride it, and so open it up and take all the mucus, all the pus, not my mucus, but all the pus out of the lesion, clean it up, get rid of the dead skin tissue, and then pack it. And he had to come back every day to have it repacked until the skin healed and pushed upwards and flattened out. So it was a big crater in the back of his neck as a result of this until the crater filled in. And that's just because, you know, the pus just kind of forces away. So you can imagine this on your skin, and you've got this lesion, and this part, you know, gets removed. When that all gets removed, then you've got this great area down here where the skin has been pushed down. And so until this pushes upwards and fills in, and then you have healed, then that needs to be packed and protected from reinfection. So that was a serious carbuncle infection. And so there's a table in your study guide, and that's what you need to fill out as some of the information about the virulence and the severity, the prevention, and the treatment for this. So how do we diagnose this? So again, I really want to focus on the diagnosis stuff, because that is something, some of you may be going into that. You may go into lab sciences or something related to that, or maybe you decide, you know what, nursing isn't for me. I really think I want to go and do medical lab science because I love microbiology so much, but who knows? So the diagnosis of this would be a gram stain. So you're going to be looking for a gram-positive coccus, and they're in grape-like clusters, which you can see here. Now, this looks like a bunch of grapes, but this is just an electron micrograph, some sort of surface scanning electron micrograph of this. So it's very much bigger, like blown up than normal. This is an MSA plate. And so it's going to be mannitol fermenting. And it's going, so that's the yellow color. And the fact that it actually grows on the plate, it means that it's salt tolerant. Sorry for my messy writing here. So anyway, but it's salt tolerant, and it is mannitol fermenting. And the other thing you'll be looking for is beta hemolysis on a blood agar plate. So those three things right there, salt tolerant, and that's why it can grow in your nose. Your nose is a very salty place. With the mucous membranes, there's a lot of salt there. And it is pretty sturdy. It can withstand high salt, extremes in pH, and high temperatures. So it's able to grow in a lot of places that other bacteria would not. So it's definitely not fastidious. It is also non-motile. So it has to find a way to get past, and that's what the exfoliative toxin is for. That's what the coagulase is for its ability to invade. So that's a little bit about the diagnosis. Here's, again, you can see the outer zone of hemolysis. It is completely clear. You can't really tell that from this picture, but you can see the blood in some areas, and then you can see the lack of blood in other areas. And it's kind of a golden color. So the aureus, this part here, is from the Greek, which means gold. And that's where we get the symbol AU for gold. And so this is the golden staph. And it was funny because my dad had a staph infection a couple of years ago, and he was taught Latin and all, you know, he knew chemistry and physics and everything. He was a physics teacher. And so they were like, oh, Staph aureus, the golden staph. Like he knew that. It was weird, not being a biologist. And also he has a little bit of Alzheimer's right now. And it was when he was kind of still, you know, with us, but he's still able to know that that is the staph, golden staph. Anyway, surprising stuff that they remember. So the MRSA is, again, you can see an example of MRSA here. Like I said, it's a carbuncle, it's a furuncle, but it's a pus-filled lesion, and it's resistant to multiple antibiotics. We used to say it was methicillin resistant. Well, now it's really multi-drug resistant Staph aureus. And again, the abscess, tender, red, and raised and pus-filled. And so it often features pus and feels hot to the touch. That's the kind of lesion that we typically see with MRSA and with the staph infections. And again, they come from breaks in the skin. So an example of this case of MRSA was, and I saw this on the news many years ago now. So, you know, this person is probably in their 30s or 30, early 30s at this point, but she was a high school student and she was a Valley Center volleyball player. And I don't remember her name, but she had it under her knee pads. And so you can imagine in athletics, you know, and especially like volleyball, they go diving for those balls and they actually sometimes those knee pads are not there and they can scrape their knee. And any kind of, maybe she was just even shaving her legs and then she put the knee pads on. If the knee pads were not cleaned properly or enough with bleach and all that kind of stuff to kill the bacteria, then it easily could have provided a way for the bacteria to get in. And then it's a nice moist environment for them to just like thrive. And yeah, so that is a big issue with sports. And so people who are going into volleyball, people who are going into other contact sports need to realize that it comes in through some sort of break in the skin, from shaving or abrasions like, you know, skinning your knee and things like that. So this is where we often see those type of infections come up on the skin. So here's just a summary table, and it is a serious threat in the category of antibiotic resistance, but we have seen the number of cases somewhat go down in the last probably 6 to 7 years. And so the incidence, however, is increasing in communities, decreasing in hospitals, but it's increasing in the communities. And so it is a serious threat. So what they'll use for this type of symptom or this particular type of infection now is this clindamycin, and TMP is trimethoprim, and sulfamethoxazole is SMZ. So that's that SXT that we would use on the antibiotic sensitivity test. And so that is and clindamycin then is a protein synthesis inhibitor. So that combination seems to be effective. They also have things like Sinercid and linezolid. I'm not sure if those are more for like systemic infection of this, but those are some of the drugs that we typically use for MRSA. So this is one of the reasons why we wanted to talk about MRSA or Staphylococcus aureus, is because of MRSA being something that is increasing in communities and something that is decreasing as a hospital acquired infection